there. Good morning / afternoon.
Hi, friends. How's everybody doing on this Wednesday?
It's Wednesday, and
Hmm.
how about you? How's things going over there? Oh, I read
Uh,
that there's
Pretty good.
major flooding happening in Kentucky, but I don't know how close that is to you.
Yeah, me personally, it's not very close, but I do have some friends and family that have been impacted, not majorly, but I know a
Yeah.
lot of people have got it a lot worse than we have, and
Mm.
we've had some deaths related to it. So,
Oh, wow. Yeah, really serious. I didn't realize that.
yeah.
I'm glad you're okay. Glad everything's okay.
All right, all our friends are popping in here.
Great to see some faces. It's like, here's who we've been talking to for the past.
Yeah, I don't know if our participants realize that we changed the format today from a webinar to a meeting, so the features are a little bit different.
Mhm.
Hey there, folks. We're just waiting for a couple more people to trickle in before we get started. We see you out there. Also, just stating this again, if you're just joining us, we do have we do have it in meeting mode right now rather than webinar mode because we're excited to get into some interactive stuff. So just letting you know that your mics are able to be used as well as your cameras. Looking forward to getting started in just a moment.
If your mic is currently on, please turn it off. Okay. Yeah, I think everybody's is off except the speakers.
Oh shoot, Laura, I didn't maybe I didn't actually tell you what I think we need. I wonder, is it possible at this time to turn on white breakout rooms as a feature or not?
Let's see. Is that under host tools?
I think that's right, yeah.
Share screen chat, rename, unmute, start. Don't see. I don't see breakout rooms. I see chat, share whiteboards, share notes, collaborate with Zoom apps. Would it be under that?
No, I don't think so. It's possible that we may not be able to do it now that we're in the meeting. I blanked on
Okay, I have
confirming this.
captions, polls, quizzes, docs, notes, whiteboards.
Yeah, it may not be enabled, and that's okay. We'll
Okay.
work around it. That's all right.
Okay.
Yeah, another meeting, yeah. Have a good day. Thank you.
Please mute your mics.
It's been a lot.
Okay. Are we ready to get started? It's 12:05.
We're ready on our end.
Okay, well, welcome everybody. This is the third part of our TIC-Talk Untangling Trauma One Step at a Time. And I'm just going to turn it over to Khalil and Ryan and let them do their thing.
All right. Thanks so much, Laura. And thanks everybody for being here. We're excited to kind of wrap up this series. This is the third part of our 3-session series. And just wanted to kind of shout out that our intention with this series and future series has been to kind of lay out some principles in the first session, talk about some concrete practices and tools in the second session. And for this third and final session, really wanting to kind of just engage with you in using some of these tools, trying to apply stuff that we've taken from earlier sessions. So our intent is to be very interactive today. It's why we're in this meeting mode rather than webinar mode. We want your cameras to be available to you and your mics to be available to you. So if yeah, let me get into it. You all know us pretty well at this point, so I won't waste our time introducing. But I did want to kind of hit you with these shared expectations, and they're different ones than before. So today, the expectations are really around just like be in dialogue with us. That's what we're excited about. We're excited to hear your ideas about how to implement trauma-informed care in your programs, how it's already happening, what new ideas we can take from today in gathering. So looking forward to kind of hearing your ideas, and we're going to ask you to unmute quite a bit and chat with us verbally. I think that'll be easier than just only relying on the chat, although that will be available too. And then we're also inviting you to turn on your camera if you have the kind of setup that allows it. We appreciate being able to see your voice, especially as we dialogue verbally. So if you've got a camera and are able to turn it on, looking forward to actually seeing your faces today for the first time in this series. Our objectives today, here's what we hope to cover. By the end of this session, this hour-and-a-half long session, we want you to be able to differentiate the 6 key principles of trauma-informed care and apply them, really, or maybe model how we could apply them, right? Number 2 is we want you to be able to discuss client scenarios using a trauma-informed approach. So kind of just trying to distill all the stuff that we've talked about, and we'll do a quick review of some of that stuff to talk about a client case in a trauma-informed way. And then finally, we want you to be able to apply verbal blending to some client scenarios, right? So we'll practice that verbal blending a little bit today. And hopefully you'll walk out with something concrete that you can apply to your programs or your practice with the folks that you work with. So here's how we're going to kind of get through it. We're going to do a very brief review of the 5 R's and the 6 key principles, and we'll do a brief review also of verbal blending. And then we're going to, rather than be in a breakout group, we're a fairly small group anyway, so we're just going to invite folks to engage in a discussion, which we have some discussion questions, some things to look at on the screen, and we'll invite you to talk at that time. And then we're going to offer some like very distilled takeaways from this 3-part series and get you on out of here. So that's our plan for today. I'm excited to get into it. As a brief review, we've said that if a program says that they're doing trauma-informed care or that they take a trauma-informed approach, we should be able to make some basic assumptions about that program, right? If you say, I'm doing trauma-informed care at our program, I should be able to look at that program and say, well, I assume that this, and this is happening, right? And these are the basic assumptions. It's a program that realizes the widespread impact of trauma and understands potential pathways for recovery, right? And we talked about the ways that like the rates of trauma just in everyday people in the United States are quite high. As high as 80% of us have experienced some form of trauma. And then when we look at the people who have experienced unsheltered homelessness or housing instability or are in supportive housing programs and are maybe dealing with substance use or mental health challenges, that number, I think, skyrockets, right? We also looked at the way that people experience adverse childhood experiences that follow them into their lives through the experience of chronic conditions and unaddressed trauma that leaves them needing quite a bit of support, right? So a program should realize that widespread impact. Further, a program should recognize the signs and symptoms of trauma in their clients, in those families, in the staff, and others involved in the system. So not only do we sort of realize the widespread impact, but we can actually recognize the behaviors that we see, the way people interact, the type of support that we need to give, recognizes how it looks. And it can look a variety of ways for different people, right? Different traumas are going to affect people differently. Some people will be able to kind of move through trauma quite quickly or traumatic events quite quickly, and others, it will stay with them for quite a while. Third, a program that is doing trauma-informed care would then respond to that trauma by fully integrating their knowledge about trauma into their policies, their procedures, and their practices, and seek to, number 4, actively resist re-traumatization, right? So the practices that we use should not only be sensitive to what people are experiencing and responsive to that, but also work very hard to not contribute additional trauma. And often that is through coercion, power dynamics, sort of putting people into boxes in ways that don't quite fit, right? And we're an overtaxed system in terms of our mental health systems, our substance use systems, our housing systems. There's not enough of all of that to go around. And so it can be, if we're not careful and mindful, too easy to fall into the trap of implementing systems that can re-traumatize folks. And then finally, we add this one to the basic SAMHSA statement. A trauma-informed care program would repair and acknowledge mistakes, right? We have some work to do to hold ourselves accountable to providing trauma-informed care. And when we mess up, when we do re-traumatize folks, or we are not sensitive enough to their needs, we can step back and say, you know what, I did that wrong. I didn't approach this in the way that I should have. And I want to make an apology and a repair for any harm that's done. So those are the basic assumptions of trauma-informed care. We call those the 5 R's. Once again, if you see this elsewhere, you might see it as the 4 R's. The repair is an addition on our part. Then we talked about the 6 key principles. And these are not like standalone. I want to make that point again here, right? Like these principles interweave everything that we do. And I think the more of these principles, any given interaction or any given intervention, we can see these principles, that is going to be a stronger intervention, a more responsive intervention, right? So the more of this that we can include in every one of our interventions is going to be lead to more successful outcomes for people. So these are the 6 key principles. Safety. We talked about both physical safety and emotional and psychological safety, right? And once again, these principles don't just apply to the work we do with our clients, they also apply to the staff, right? Who are also people who perhaps have experienced trauma. In fact, it's likely that they have, given what we know about rates of trauma, right? So not just safety for our participants, but safety for us as workers or managers or executives, right? Trustworthiness and transparency, being open and honest with people allows people to make decisions for their own lives. Peer support, we talked about that quite a bit in the way that lived experience can offer a perspective of hope. It can offer a perspective of understanding that folks without that lived experience may struggle to meet people where they're at in some ways, right? And so incorporating significant peer support is critical here. I'll also say at other levels of the organization, that peer support is so necessary, or bringing lived experience into the decision-making rooms of an agency has a huge impact on the way services can be rolled out. Collaboration and mutuality is the next one. And just being in a partnership with folks that we work with, right? It is their lives, and we're there to collaborate, offer ideas, offer suggestions, be in a mutual relationship that allows us as workers to be human beings, right? We are people too, and we're engaging in something that is that at its foundation, that therapeutic rapport or relationship is the necessary factor for healing and growth, right? So this collaborative mentality allows us to tap into that. Empowerment, voice, and choice, I think, is self-explanatory. We're focusing on strength-based practices, allowing people to voice their own needs and desires, and giving people the choice about what they're going to do, even if we know there might be natural consequences to some of those choices. It's their life. And so we're there to help pick up the pieces when necessary. And then finally, cultural, historical, and gender issues. I do think this can be quite tied to the peer support principle, right? Where when we have people who are like us, who meet us in that identity space in helpful ways, is one way that we can embody this principle. But bearing in mind an understanding of intergenerational trauma and historical trauma and the ways that racial and gender minorities have been affected by harmful practices and higher levels of experienced traumatic events. Okay, so those are the 5 R's. Those are the 6 key principles. That's a review of what we've talked about so far. We're ready to start engaging now in how do we put some of this stuff into practice. And we really want this to be a discussion, right? So we had intended to do it in groups, but let's just do it principle by principle. I have a couple questions on the screen, and I'm going to stop doing so much talking and invite you to open up your mics, turn on your cameras. But I would like to brainstorm in your programs. What are all the ways that you can think of that you think your program embodies the principle of safety, right? How does your program, both for the staff and the participants, embody this principle of safety, psychological safety, emotional safety, physical safety? What are the things that you do? And I'd like for us to learn from each other. All right, I'm done talking. So if you'd like to use your Zoom hand to raise your hand, you can do that, or you can just unmute and just go for it. I think we're a small enough group that is possible.
I
Oh, go ahead.
I just wanted to add, sometimes these are things that we're doing with not necessarily safety in mind necessarily on the front, but are still trauma informed. So some of the examples that we gave a couple of weeks ago were the idea of are we letting folks know that next week this meeting is at 3 o'clock instead of 2 o'clock, right? Avoiding surprises, making sure folks we're maintaining consistency if we can, and giving folks a heads up is an example of something very small that we're probably already doing that looks like trauma informed care. Sorry to cut you off, Joy. Take it away. The floor is
Oh,
yours.
no, you're fine. It's hard to know who's getting ready to speak when you're in the Zoom call, but thank you for this topic. And I think at Aetna Better Health of Kentucky, where I currently work, we have a lot of trauma-informed care trainings not only for our care managers, because they need to know too, right, what trauma-informed care looks like and how they can really work better for our members, but also at Aetna, we are the sole Medicaid provider for children and youth in the child welfare and juvenile justice systems. And, just that population of focus alone, they have a lot of trauma. And so we really do have a lot, like this last weekend, we went to train a group of foster parents on trauma-informed care and those ACEs, the adverse childhood experiences, what are those positive childhood experiences, and how they can kind of offset, just to truly try to change the mindset and have folks get a better understanding of, there's really trauma in this person's life, and so they might be acting or behaving one way, but it really, trauma plays a really important factor in that. So we really do try to do a lot of those trainings, not only to our care managers and to the parents, but also to the youth as well. So, I mean, that's that's one of the things that I can think of. We have a trauma-informed care training coming up soon. As well for partners and stakeholders. And my VPN keeps shutting in and out, so if I freeze up, I'm sorry.
Yeah, thanks for chiming in on Joy. I love all that. And if I could like me put an even finer point on some of what you said in terms of the connection to this principle of safety, I think being the sole Medicaid provider in the way that you said, it does contribute to safety, right? Like how can we be sort of physically safe, for example, if we don't have medical insurance and we can't see a doctor when we need to, or be responsive to harms that have occurred, right? And so I think there is a safety net component to your work that embodies this principle quite a bit. And then it sounds like also the training that you do as a way to embody that principle as well. I love it. Who else? What are you doing at your programs that you think really embodies this principle of safety already? And it doesn't, I love Kalo's point that like, it doesn't have to be because your manager said, we're doing this thing because it means safety. But we can sort of connect the dots a little bit and say, wait a minute, this is supportive of emotional safety in this case, or physical safety. What are you doing in your programs?
I would say like the boundaries between my clients and I, and learning what those boundaries were, because this is my first case management role. So I would say that making sure that, I'm working only within my assigned work hours, things like that.
I think that that's a wonderful example of when trauma from care can get messy and hairy. Boundaries are not quick and easy. Sometimes we talk about them as like being a quick fix, like, oh, you just need to set this boundary, right? And then sometimes our boundary setting can maybe bring something up for a client that feels really activating. So I'm wondering for you, Kat, what setting boundaries through like a trauma from care lens looks like in this new role that you have for you. What's that looked like so far?
I would say one of them would be I um I work with Hispanic immigrants, and there's like a cultural aspect where it's very common to like invite people in and like be a good host and have people, like, oh, come to my apartment, like you helped me with this thing, and now you can come to my house and I can serve you dinner, which is really sweet. But for me, it's like I remember my talking to my supervisor about it, and it's like, how do we set those boundaries to ensure that, you know, you're a safe place for that client, but you're not, their best friend kind of thing, if that makes sense.
Yeah, I think it makes a lot of sense. And I think you added another layer there of like, I am in supervision and talking about this, right? It's another thing that keeps us safe, keeps our participants safe as well. Being in like consistent communication about how to like honor somebody's culture, right? And what our interactions look like, but also be thinking about the safety piece and what's coming up for you and participants around that. Anything to add there, Ryan?
Yeah, I think that is such a good example of like, come to dinner because we're close. But then if you do come to dinner, there is a perceived level of closeness that maybe some later boundary setting it feels like a mismatch, right? Wait a minute, you came to dinner, but like you're not going to give me a bus pass today, or you know, there's so many things that could come up that cross wires that make it the potential to not be safe if you're not managing those boundaries correctly. There's like emotional safety I'm thinking of. They're going to be hurt, right? If you do go to dinner now, but don't do X, Y, and Z later, or so many other ways that could play out. Yeah, I appreciate that a lot.
Can I say
What
something about
else? Oh,
boundaries
go
too?
ahead. Yeah.
Even if our clients don't necessarily like our boundaries, when we stick to them, it sends a message that we're dependable. You know, that consistency, even if they push back against it, eventually, you know, they understand that they know when we are available. They know when they can count on us to be there. And if we say that, you know, we have open office hours from this time to this time, and we stick to that, they may not like that, you know, we're only available during that time, but it also helps build trust that when I say I'm going to be available for you during this time, I am available for you during this time. So you can count
Yeah.
on me. My word is good, and that can help clients feel safe.
Absolutely. Dependability as a form of safety, right?
Yeah.
Like I
Yeah.
can rely on this person, as well as the next principle, which we'll talk about, trust and transparency, right? And that's where you see so many of these start to like interweave. It's hard to like pick them apart in this very like concrete way that we're doing. But yeah, I love that.
I just want to say, I know we need to move through these, but I think the reason that I think that's a great example is because last week or 2 weeks ago we talked about being a solid object for participants, right? Who maybe feel out of control or are not all together in a given moment or in a specific situation. So that idea of like conveying or I think displaying confidence, I think is super helpful. Even when participants are like, well, this sucks. It's like, well, they know they can come back tomorrow, right? Between this time and this time, and that you will be there for them. And I think that's awesome.
Yeah. Some other quick things that are just coming to mind for me before we move to the next question. Having crisis intervention training, right, is one way to support people's safety, right? If the staff have the tools that they need to like de-escalate situations, and participants and clients can see that or see that in action, that's going to contribute to a greater sense of safety. Things like private meeting rooms, where I know I can, as a client, can go and vent and share and bare my soul to somebody without other people knowing, right? Or without other people sort of witnessing, that can be an incredibly affirming and safe practice. Yeah, those are some quick ones that come to mind. So let's move on to this next question. What are some improvements that you'd like to see your program make specifically in the area of safety? Can anybody think, and I'm not asking you to like talk badly about your programs, but I'm curious to know, like, is there anything that you've seen or anything that you've heard in this training series that say, you know what, I wish we did X, Y, and Z a little differently, or this is one way we could improve sense of safety for folks? What comes to mind for?
One of the things that I've seen a lot in shelter settings specifically are shifts where there is one person responsible for many people, right? So if there is a crisis or if people are physically harming one another or trying to harm staff, there's not a ton of backup there to be supporting you and your own safety as a provider, but also the safety of residents involved. And I think that's a kind of nuanced example, but dealing with the safety of staff and participants in a program, I think about some census issues. So I guess like the recommendation would be, if we see this in our program, to have something that feels like a little bit of a fail-safe, right? That there's maybe never somebody alone in our shelter setting.
Another thing that comes to mind for me, and I do want you all to like give your ideas, because otherwise we're just like we're going to take over and keep talking. And I don't want that to be true. I want you to be able to get something from this session. But it can often feel unsafe as a staff member to share feedback about an organization when we don't feel safe, right? Or something is happening and we don't feel safe enough to be able to share that with management without reprisal, right? And so I think if your organization doesn't have some pathway to get feedback from direct service up through management, then I think that's one way that like safety could be greatly increased, improved, thought about. What else? Can one other person chime in? What's an improvement that you'd like to see in your residence, or excuse me, in your residences, in your program, whatever it may be?
So for me, I wish that I work at a shelter, a day shelter, and I wish that we got more training just to be more trauma informed, better de-escalation training, because I feel like that just makes everyone safer if we can just avoid the situation happening in the first place.
Sort of like a preventive measure, right? Like we have the tools. It doesn't need to get as far as it sometimes can get. We can just de-escalate early. You do get some of that training. You just feel like it's not enough, basically.
Yeah, basically, I feel like it's not enough. A lot of our staff, we're busy, always like very busy. And so if you aren't individually taking the time to seek out these trainings or to schedule yourself for these trainings, I feel that you probably won't get enough training in trauma-informed care and de-escalation.
Yeah, I do know it can be really tough to it can be like a logistics nightmare, I think, sometimes for management to figure out how to get shelter staff trained because of all the different shifts and stuff. But I've seen it done well, right? Where maybe people will, programs will incentivize, come in on your off day or come in on like, if you're a night shift, stay through until 12 the next day or whatever, and we'll feed you lunch and maybe give you a gift card. There's ways that people try and like incentivize the mixing of shifts so that everybody can get these tools, because otherwise you're like only focusing on the day shift, or like you said, like asking people to kind of do it themselves.
Yeah, and I think it can be hard sometimes to find quality trainers. Like you never know what you're going to get with certain programs, and
yeah, I appreciate that too. Yep. So maybe doing the work, like the legwork of finding good trainers that maybe other shelters in your area have like networking to be able to like support each other, I think is a safety practice in that way. Cool. All right, let us move on to our next principle. And it's the same two questions, right? So we're going to kind of go through each of these 6 principles, and we don't have to linger super long on every one, but what are the ways that you feel like your programs are currently doing a really good job of implementing trustworthiness and transparency? How are you being trustworthy and transparency for the workers and for the clients and participants who you're supporting? And so we'll just leave this out there. Please feel free to unmute and jump on in. I see your face, Alan. Say something to us. Oh, you're muted.
How's that?
Yes, I hear you.
All right, good.
There you are.
I think making expectations clear and not just expectations of what you expect from the clients, but what the clients can expect from you as a service provider, I think is one of the areas that I think is very, very important to curtail those expectations, to not give false hope on what you can provide, but be very, very realistic in sharing what you can and cannot do, what your program can and cannot do. I think that's just extremely important as far as transparency, but it also brings integrity as a big part of what you do. So
totally. I really appreciate that answer. I wonder if if there are ways that you at your program I think it could be very easy to like say that, and maybe you've got some providers that just like automatically have that level of integrity, or they've been doing the work a long time and they know not to overpromise. But how do we make sure that like everybody is kind of meeting that same standard? What are the expectations? How are we sharing them? Is there any kind of training that you do to make sure that that happens across the board? How do you manage that there in your program?
Well, with us, at least in my part, we have different grants here at the spot. And so different grants have different funding sources that can do different things.
Yeah.
And so I try to make it very, very clear when I'm talking about what my piece of the grant can provide. And I also do that across the board with other staff in other grants so that they're not presenting our grant and I'm not presenting their grant in a way that's not true to what they can do. So I'm not trying to set up other staff to have to reach a certain level, but I also want to make it very, very clear about what we can do. And so I think cross communication with programs, if you've got multiple programs in your building or in your overall program, there's different aspects of that, communicating those things, trying to make it very clear. I work in housing, so I get a lot of expectations when people come. Oh, you can give me this, you can give me that, you can do this, you can do that. Not necessarily. And so
Yeah.
I've tried to help my coworkers curve those expectations when they encounter them. So when they do come to me, there is a certain level of understanding of what can happen.
Yeah, no, yeah, I appreciate that a lot, especially the cross communication point. And what I've even seen in some locations or some programs is making it a habit of having little mini presentations for certain sections of the staff, right? Housing wants to talk about this new grant that we got, and we want to share that with all the staff so that you're aware. So it's not just the communication directly with the participants, but our teammates need to know about each other's work. And sometimes we can get a little siloed, even in a single agency, because we're invested in our own roles, right? I don't want to be thinking about your grants and your roles and all that stuff, but sometimes we need to. But yeah, thanks, Alan, for that. Any other thoughts folks are having about ways that your programs embody trustworthiness and transparency?
We try and practice consistency. We aren't perfect at it, but I feel like it helps with the trustworthiness because they know that, if this staff member said this, that's what's going to happen. And hopefully, ideally, we keep doing that. And, they know what to expect and things are clear.
Yeah, sounds like a similar idea, right? Like staff have to be on the same page, basically. Yep, communicating with one another about expectations. Yeah, I think sometimes folks are looking for the softies, right? Well, if I ask Kirby, maybe I'll get X, Y, and Z extra that maybe Kala wouldn't let me have or whatever. And so, yeah, holding the line sometimes on some of those expectations can be a tricky thing. All right, I'm wondering if anybody might be willing to share improvements that you would like to see at your agency related to trustworthiness and transparency. Remember, thinking about both staff and client experiences. What improvements do you think your program could stand to make to be better trauma informed in this way?
I think some of the ways that we can build trustworthy and transparency in our agencies is be mindful of what the environment might look like, as well. Like one time in my previous role, the receptionist had a pretty stigmatizing meme taped on her desk as far as what the individuals are going through, and so when somebody sees that, it's automatically off-putting. And so, just to be cognizant of the environment, are there resources out in the lobby area? Are there, magazines that people can read while they're waiting? What color even is the paint on your walls? Is it more soothing? Is it more calm? Is it recovery oriented? Or is it, more of the institutionalized type of paint. So I think it's just kind of scanning over your environment and taking down anything that might look or feel stigmatizing, and making it like a more welcoming environment. And this doesn't only go for, homeless shelters, but also, mental health agencies. When folks walk in, how do they feel? Are they welcome? Because sometimes it might be their first and only impression, and they might not ever come back. So I think that's one way to really, just to, on that unconscious level, to build some of that trustworthiness as well.
Yeah, I like that. I mean, if somebody sees that, if I'm talking in like a really person-centered and supportive way to a client, but then they look over on my desk and see like a stigmatizing meme, I'm being two-faced there, right? I'm not actually um something is not authentic. One of the two of those things is not authentic, right? And that's going to damage trust at some point, right? So, yeah. And we have to cope also, right? I think we like to talk about the ways that like some of those things are natural adaptive responses to secondary traumatic stress and burnout. And yet can we find ways to cope and adapt to our secondary traumatic stress as workers that isn't gonna damage the relationships with the folks we serve, right? Yeah, I don't know. Go ahead, Carlo. Do you want to add something?
I do appreciate what Ryan is saying, and that some of these things are like symptoms of, bigger things like burnout, compassion fatigue, and like secondary traumatic stress. But also, there's a lot of things that are avoidable. Joy, in your example, it sounds like somebody took a couple more steps to make people feel uncomfortable and like posting a meme or something, right? Which is like, if you're burnt out and tired, don't do that. Right there. If you're already tired, that's maybe something we don't need to do. Um I appreciate that example. I used to work in a methadone clinic where one of the security guards and one of and somebody else, like an admin person, posted something that said like wow wow wow, like call the ambulance, like in like the waiting room. And I think the actual complaint somebody submitted was like, this doesn't feel very trauma informed, and they were asked to take that down. But yeah, so I think like it sure symptoms of burnout and compassion fatigue, but also some things are just like mean, even outside of the helping profession. If you do that to somebody, they're not going to feel welcome.
Yeah, when I was in programs where I supervised staff and was in charge of uh, buildings and facilities, one of the things I did was I changed all the signage to be stated as positively as possible. So instead of no smoking, it was please enjoy your tobacco products in designated areas. Instead of don't prop this door open, please leave this door closed. And little things like that, you may not even need a supervisor's permission to do. You can just take that upon yourself to state some things in a positive manner. And those kinds of things, set a tone and send a message. People are told no, no, stop, don't quit all day long, every day. And, we've been talking a lot about boundaries. That this is a way to set a boundary with people in a way that doesn't feel like they're being bossed around.
Yeah, I love that a lot. But I think what that requires is like a pretty close attunement to your environment, right? And sometimes even those like no, no, no messages are so familiar to all of us, we look right past it, right? I don't even notice that sign that says don't smoke here because like those signs are everywhere, right? And so we do have to be quite well attuned to our environment and like be intentional about some of those decisions. You had to, and probably it took you, I think you said you came new to that place and that was one of the first things you did. That is often the way that we can implement this stuff is like look at it with fresh eyes because once we've been there for a couple of weeks or a couple of months, we're like almost, it's almost invisible, that stuff, right? And yet it does still have this impact on people.
And I actually learned that from when I worked in facilities for small children. We always try to be positive with children instead of saying, don't run in the building. We say, let's use our walking feet. Let's use our indoor voice. And so I thought, why can't we transfer that to adults? And
Yeah.
so I just took a survey of the lay of the land and looked at all the signage and decided we can say this in ways that are much more positive. And it just sets a tone for everybody, for clients and staff.
Yep. Totally agree. I love it. All right, moving on to the next one. What are the ways that your programs are currently embodying the principle of peer support? I think this is a much more practically focused principle, right? Is there peer support at your program? How does it look? What function do the peer support role folks play? Yeah, the end. What are your comments here, folks? Maybe the simplest question is there peer support in your programs?
I think there could be more.
Yeah, it sounds like there is, but you don't feel like it rises to the level that you'd like to see? Yeah.
Yeah, I think too, it's like my position is because I work with a specific population that our other caseworkers don't, it's sometimes isolating. That makes sense.
Yeah. Probably would be nice to have a little extra like lived experience to support that work. Yep.
Early in my career, when all I had was a degree and no experience, my clients became my best teachers. This was before there was peer support, before that became a movement. And my clients honestly were my best teachers. And so I was really happy when the peer support concept became a big thing, and that those people with the lived experience were given credit and jobs and credibility. Um, yeah, I agree. We don't have enough of it. And if you're in a position where it's not there, then find some clients who maybe fit that bill, even if it's not officially, and let them guide you and teach you and
Yeah, I think that's
advocate for it.
crucial.
Advocate.
Yeah, I mean, I think we talked about this when we delivered some of this content earlier in our training series, but I think one of the things that we see or we've seen, both Khalil and I, is that maybe an agency like employs peer support, but they often function in this like junior case manager role, right? At one agency that we worked at, um, it was almost like they were case managers just like everybody else, but they got paid less, right? Or they weren't even billable. Their service wasn't even billable, and some of that comes down to like Medicaid restrictions and that's state by state. But I think there's an implicit message of, yeah, we want to have peer support, but like it's not as good as actual care, right? And so I think fighting some of that stigma is a critical role that we can play in our programs. And then we have a former colleague who gets on this bandwagon quite a bit, but um, he talks about allowing people who with lived experience who maybe came on as peer support professionals to move up in the agency. Like, don't trap them as peer support professionals for the entirety of their career. Allow these folks to like rise through the ranks into leadership because that same lived experience is going to play a pretty big role in the decision-making process for better supporting the folks who are in the program, right? So one can still be a peer support professional, but also be an executive director, for example, or some other management position. So that's one gap that I think we've seen. Anybody else have any last comments on peer support before we move on?
Yes, I do. I work for a healthcare agency, healthcare for the homeless, and we have peer supports in our different areas. And basically, some of them they do work as case managers because we have some in one in our respiratory department, and I work in social services outreach. So we have a peer support person. He's also like the greeter, so he's the first person that you see when you come into our facility. So they do play an important role
Nice.
where I work at.
Nice. I love that. And I want to be clear with one of my statements. I don't think that peer support professionals should not be case managers, but I don't like to see that they are sometimes compensated less than non-peer case managers. I'm curious to know do you have any thoughts there? Does that happen where you work or?
Yes, it does. Yes,
Yeah.
it does.
Yeah.
Yeah. Because like basically we have a peer support person in our respite unit that does the same as our case manager does, but there's a slightly significant pay difference. Yeah.
Yeah, that's tough to see. I think it contributes to like just an ongoing level of stigma, or it doesn't fight it at the very least, right?
Yeah.
Great. Okay. Any last comments then on peer support? Okay. Okay. The next principle is collaboration and mutuality. I'm curious from your perspectives, what are the ways that your agencies, your communities are really actively embodying this principle of collaboration and mutuality in your work? Once again, thinking both about staff and client experiences. Is it collaborative? Is it mutual? Meaning like kind of this reciprocal type relationship that can sometimes exist in care with boundaries. What do you see there? What's going well in your programs with respect to collaboration and mutuality?
If anybody is responsible for treatment planning in your roles, this might be an opportunity to share what that looks like or could look like if it was more collaborative.
think
I
a
think
lot
one
of
way that we,
time,
oh, go for it.
sorry,
Sorry.
I was just going to say, I think a lot of time our role when we're working with folks that, during treatment plan, and just for the sake of time, sometimes we go ahead and fill it out and then we hand it to the folks and say, here, sign this. And they sign it, right? Because that's just what they're doing. And so that means sign it, whether it's good for them or not, whether it's something that they can do or not. And so really just kind of sharing back, hey, what is this going to work for you? Do you have other things that you would like to do? And doing sometimes that collaborative documentation. And my internet has been going crazy. And so if I freeze up, I'm sorry. I'm gonna turn my camera off. Maybe that might help. And I think that, just being able to have that collaborative documentation and having that person sit next to you while you're doing it, just to make sure that you both are on the same page. And I think the most important thing, and it goes with person centered, is to see if this is something that they really want to do and if it will fit within their lifestyle, within their purpose too. And so then you don't end up with a lot of quote unquote non-compliant folks. Well, it wasn't the person that was non-compliant, it was a plan that didn't work, right? And so it's just really having that mutual understanding and collaboration and respect.
Yeah, I really love and appreciate that idea. And it's easy to do. It's easy to just do a treatment plan, have someone sign it. That is like the most accessible option to us sometimes when that is our role. But then also we're frustrated sometimes when clients aren't meeting like treatment goals, right? But they weren't involved in the process. That choice is important, and that our folks do want to be responsible for kind of healing on their own. So thanks for sharing that, Joy.
I wanted to give another idea here with collaboration and mutuality that I don't think we said it so far in this training series, but I think being on an interdisciplinary team is an example of collaboration at the staff level. Being able to like learn from the street-based nurse about wound care and being able to like make a warm handoff because I've got the great relationship with the client and we got to get them into medical care, right? So many ways that like the interdisciplinary team can support one another through a lens of collaboration that is so supportive of people's goals often, right? And healing. So I want to just make a plug for interprofessional care. We're coming from a setting where it was ACT teams. So it was like anywhere from 8 to 12 professionals on a team with a shared caseload. I think for me, that's the only place I've worked that like had that. Usually it's like one case manager out there kind of flapping in the wind, it feels like. And so when you can have professionals to bounce ideas off of, maybe from a different discipline, different lens, can be just like so supportive. Okay. I wanted to know if anybody had anything like maybe more critical to say about collaboration and mutuality. Are your programs doing things that you think could up the collaboration, up the mutuality in your practices? What are you seeing in your agencies?
I know like some of our procedures are different across departments, and so when I came into my role, there wasn't really like set procedures that were similar to the rest of the organization, and so I'm trying to readapt it so that it's more similar to what other departments are doing, just so that we can talk about it and compare and stuff like that.
I like that. I actually think that does have like a role to play in trauma-informed care, right? Because people can know what it goes back to expectations that we were talking about earlier, right? People know what to expect from your program as opposed to another program, both staff and clients. So yeah, I like that. Improving the collaboration and mutuality by matching our policies and procedures to like other teams. That makes a lot of sense to me. Cool. All right. Let's go on to the next one. Empowerment, voice, and choice. What are folks seeing with respect to this one? What's going really well with empowerment, voice, and choice in your programs? I like kind of am going to get ready and get silly and start calling on people that are out here. Give me an answer, somebody who hasn't spoken yet. I'm scared to do it, though. I don't want somebody to be mad at me. Go ahead.
Also open to just like firing off stuff in the chat if you don't want to be on camera. Or unmuting in the way that Monique did to still share but remain off camera. This is your chance to practice your trauma-informed care skills and what you've learned the past couple weeks. Or what you're already doing or want to be doing more of. Well, while everybody's thinking, I think an example is including folks in our agencies on our boards, right? Or in the room or creating policy. I think that's going to affect and impact the care folks are receiving. That's something that an agency that Ryan and I worked at was doing in specific places. I think specifically like a safety committee and a policy committee, right? There were folks from that agency receiving services included in those spaces, which I think really speaks to that idea of empowerment.
Also from like a housing perspective, offering folks multiple options for places, which is not always possible, right? Like the housing stock is low. If we have a spot to put somebody in, we just feel lucky that we have that spot. But I definitely have worked in an agency where they said, okay, you can have up to 3 options, right? You got to say yes to one of them. Otherwise, you're going to get bumped down the wait list, right? Nope, I don't like that one. It's too close to X, Y, and Z. Nope, I don't like that one. I want to be close to the river. Oh, nope, I don't like that one. I want to be downtown. Okay, fine. You can say no to all of those. That's your choice, right? We're not going to force you into any of these. But if you say no to every single one, we might prioritize other people's needs first because we don't have what you need right now. But allowing people to make that choice of this apartment or this apartment is huge, right? That's a place where I'm going to live. And I wanted to like reflect my needs and like meet all my needs. So I think that's one pretty cool way of supporting empowerment, voice, and choice.
Our shelter, we have a PSH program and we follow the housing first model. So pretty much people don't have to get treatment. They don't have to go into any kind of therapy or anything. It's just get them into houses. And I think that is a good way that we empower choice, because they can choose to live their life the way they want to and still have that basic need met.
Absolutely. I think that's a great example. Any kind of housing first program, I think automatically is supportive of that level of choice. Nope, you don't have to be in treatment. But then there's like this, then we do have to have more conversations around like what's going on. Are you going to lose your apartment because of choices that you're making? You can keep making those choices, but you might not be here forever, right? I want to let you know, right? So continually coming back to those choices through an accountability lenses is really important. That's a great example. Okay, last one. Culture. Oh, I see you unmuting, Laura. Did you want to add something there?
Well, I was gonna, you were joking about calling somebody out. I was gonna call out Charlie Walsh if he's able to speak about empowerment, voice, and choice in the coordinated shelter access. You know, Kirby, you're kind of at the other end of it, that point where people are being referred to housing, and Charlie's on the first end of it when people are calling about, is there a shelter bed available, and talk about empowerment, voice, and choice at the front end of it. Are you there, Charlie?
I am, Laura. Yes. I don't necessarily know what I have to add. In part because our current shelter situation is so limited.
Mm-hmm.
So I don't feel like there's much choice. In fact, we have the opposite, that there's certain shelters that people like and want so much more.
Mm-hmm.
And there's a lot of anger around the fact that they can't get in there. Because those are full all the time. And, I wish there could be a discussion about the good shelters and making them more available, and the bad shelters could get better. But really, I'm just a crossroads person.
That sounds like a huge issue.
It is. It's something that we battle all the time. But I think that the voice and the choice, even though it's extremely limited, the fact that they have a kind person like Charlie, a caring person like Charlie, who will at least listen to them and go over what limited options are available in a kind and supportive way, and encourage them, keep calling back, keep checking in. They're tiny choices, but even those things make a difference with people.
Yeah, I 100% agree. Even those tiny choices, I think we have to keep presenting them as choices. Like, hey, this is your choice. I know it's not ideal, but here we are. Here's a choice. There may be consequences to not making a choice, or there may be consequences to the choice that you make, but at least I want you to know that, like, these are the options. And I think kind of continuing to bring it back to that conversation is probably the only way to deal with that case where you feel like your choices are limited as a provider. I wanted to read Susanna's comment. I think she made it much earlier, but I'm not sure exactly when she made it, but in the chat it says, ensuring our folks we support feel empowered to self-advocate for their needs, providing options and choice when possible, keeping sessions, interactions, and planning client-centered as much as possible. Having autonomy and personal sovereignty are so important. Susanna says they're probably repeating some things, but I think you're right on track, Susanna. I think that's exactly right. Finding little ways to keep things, even our mini interactions, as choice-based as possible, as like autonomy supporting as possible. That stuff stacks up and adds up for people in terms of building trust, allowing a sense of safety. So yeah, I agree with y'all. Okay. Last one, just really quickly. If anybody has anything to say about culture, historic, and gender issues, now's the time. In what ways are you doing this really well? In what ways are you struggling to present this or have this principle embodied? Cultural, historic, and gender issues. Wonder if folks have thoughts here.
I mean, sometimes it's hard because you want to be culturally cognizant, but then, like, for me, if I'm working with people who, like, especially male presenting clients with, like, machismo or, like, that idea, but then as a female caseworker, it's just kind of a strange it's a strange, I don't know, situation. So I think that that's something that I constantly have to work through because there's the cultural expectations that I wanna respect, but then where does that cross the line into just being not right, you know?
Yeah, and I think one way, or one of the things we like to keep front of mind when we're thinking about services that are culturally responsive services are, this might be your experience with folks presenting in this way, but also hopefully knowing that there's room for, even within that culture, for folks who are like, actually, this isn't very healthy for us, right? And not viewing cultures through like like a monolithic sort of lens. But certainly a challenge sometimes, I'm sure, right? If this is your experience with folks directly, the folks that you're coming across and being tasked to work with. Yeah, thanks for sharing that. I think it paints a picture of like it not being simple and easy all the time to be trauma informed. Does that mean I have to um like open my own self up to harm? And I hope that that's not the message that we're sending across. It's like you don't have to be soft, I think is sometimes the um like the label trauma informed care might get sometimes. Um, but it is not that, right? Trauma informed care has some tools, has some evidence here. So yeah.
Can I just add, yeah, I love everything that you said, Khalil, and also this idea that like just because this individual is acting in this way and seems to be like representing this culture, they're not like representative of a whole culture. And I think we can ask that we can name some of that stuff. Hey, I noticed that you're acting like this every time we get together. Where does that come from? You can have a conversation about culture within that then by
Yeah.
sort of naming it directly. And also you get to be in a mutual relationship with this person. Hey, and when you do and say this, I receive it this way, right? I'm not sure if that's how you want me to receive it, but here is me as a person showing up. Because right now you're dealing with stuff that is going to be coming up for that person all throughout their life, right? And so in the almost like a psychodynamic therapy sort of way, not asking you to be a psychodynamic therapist, but we can name stuff and talk about it and call it out. And I think that is a cultural opportunity that deals with these issues and like wrestles with it in healthy ways, that models for people. Oh, Kat did not like that when I said that way. Or maybe they steamroll you and not, and you can like put more safe boundaries up for yourself in that case, right? But at least you've like tried to engage that cultural issue a little bit.
Mhm.
Okay, thanks folks for kind of brainstorming a little bit. I know this is a hard conversation we're coming from different places, coming from different settings. I don't know. This is a tough meeting, I think, to engage in, but hopefully this next activity or this next experience will allow for maybe some more concrete engagement. I'll toss it over to you, Khalil.
Awesome. So I'm going to talk about a specific skill that we call verbal blending. And this is actually a tool that we introduced during our last meeting together, but we're going to have an opportunity to practice this. And if trauma from care is more difficult or feels kind of abstract to be thinking about, or maybe we're newer to these spaces, I think walking away with some actionable items and skills around language might be the door or the key that opens these doors up for you. Because it certainly wasn't my case, especially with the idea of verbal blending. Somebody gave me language to use or gave me kind of a formula to use. And it just trickled into many of my interactions afterward, right? So verbal blending specifically is a tool that is supposed to, or not supposed to be used, but comes out of like the crisis space and de-escalation space. This is how we want to kind of literally think about blending with your participants or the person you might be de-escalating or intervening with during a crisis. But we can also use it outside of crisis situations for just a regular schmegular relationship building. And I like to think that this could also exist in a motivational interviewing space as well, if folks are familiar with that idea. But this is a way that we are really coming alongside our participants and the folks that we're serving in a way that is non-directive, um, but still a supportive communication style that really centers around that collaboration piece rather than coercion, right? It's really easy to say you have to do this because I said so, right? Or because I told you to, or because that's the policy or that's our rule. And I really want to challenge that. There might be a chance that folks in this space have said that's the policy, right? And I really want to just encourage folks to think about what that means, if it means anything to somebody, right? What it means to you, what it means to be the policy, because sometimes our policies are harmful, right? If we think back to that last key principle, cultural, historic, and gender issues, some rules are just harmful to folks, right? Disproportionately. We know a ton about disparities in the homelessness space and that exist in the country and in the world. Um, So doing as much as we can to move away from like a coercive space and really think about, is this policy for safety, right? Or is it a rule just for the sake of a rule and to have some control? Um, so verbal blending focuses on shared decision making and empowerment, avoiding forceful directives, like because I said so. So I have a fun example here. This is actually also the same example I shared last week. So I want you to imagine, no, I don't want you to imagine because this is a real scenario. This happened. I'm just going to tell you the story. I was working at a youth shelter, and this youth shelter had a sort of like a merit-based system for folks to be earning allowance. And I have some funky feelings about that, but whatever. I was a little guy at the time and a baby social worker new to the space, and I was like, cool, I'll do it for a paycheck, right? And I thought I was doing the Lord's work. I really did. But on one evening, one particular young person's chore that enables them to earn allowance, and then we could do fun things with that allowance, was to load the dishwasher after like our meal time. And she was really struggling to load the dishwasher, and she wasn't yelling at me, but she was telling me like, you know what? I don't want to load the dishwasher. You can't make me load the dishwasher. And in fact, I know you have to load the dishwasher if I don't do it, right? Even more reason for me not to load the dishwasher. Um, and I could have easily responded to this young person and said, you know what? Okay, I'm going to take your allowance, right? Or you're not going to get your allowance, or X, Y, and Z punishment. I could have responded probably pretty punitively, pretty quickly, right? So those are some examples of what it looks like to respond with power and coercion, right? If you don't finish loading the dishwasher, I'm taking your allowance away. What it might look like to verbally blend with this participant, with this young person, might look like this on the right. You're right. I can't make you do it. I can't make you load a dishwasher, but I want to support you in earning your allowance and going skating this weekend. What can I do to support you? Right? I knew that this young person wanted to spend her allowance. She liked to go skating, and we did that sometimes. So that's pulling out a goal, right? Something we could collaborate on. I know this is a self-identified goal for her, something she likes to do. Um, and I'm bringing that up. And it's not me dangling her allowance over her head. It is me literally trying to cheer her on in earning her allowance so that she can do what she wants with that allowance and go skating on the weekend, right? So that's an example of what verbal blending could look like. And what's really important here, again, is that I think this is the empowerment, voice, and choice sort of principle here, loud and clear, right? Because this youth can still tell me, F you, Khalil, not loading the dishwasher, right? And she can go to bed. She can still very much say, no, I'm not doing this, or you can take my allowance. And that is okay, right? Especially from a trauma-informed care lens. We don't need the goal to be to win. There's nothing to win here. This is not a competition. This is not us like fighting or battling with our participants, right? We want to support them in the ways that we can. And I did offer a choice, right? If she did make the decision to not want to load a dishwasher, she has that information that she won't be earning her allowance. And that's less of what I'm doing for her and more of a choice that she is knowingly making, right? So that's a quick and dirty example of verbal blending, a skill that I really appreciate and was kind of the evolution of trauma-informed care in my own life and how to apply it. And we're going to move on through to some other examples of what it might sound like in some of our own, or maybe your own service settings. So we're going to throw something up on the screen, and I'd love somebody or somebodies to take a stab at maybe trying to blend with this statement, right? Really emphasizing the idea of trust and autonomy is probably going to be an important thing to do there. There's choice and you have autonomy here is what we want to be conveying in our responses. But so something maybe you've heard in your agency might sound like this. Why do you always knock on my door and wake me up all the time? Why can't you give me a heads up and let me prepare? If your job is in the housing first space, or if you've ever done home visits, this might be something you've heard before, right? Or something you're familiar with. How might we connect with this participant? in a way that doesn't feel or sound like, well, you need to get a home visit this many times a month. Or I'm just doing my job. What's a way that this might sound more trauma informed? And this is a laboratory. You can mess this up and we can talk about it, right? This doesn't have to be a perfect statement. In fact, that example of like that really good verbal blending example probably is very far from what I said to that young person, right? This is something that we are learning and will change over time. It should be changing and evolving for us. So somebody I'd love if you took a stab at maybe rewording this in a way that feels more trauma informed. How about this? We're going to share some other examples on the screen, and maybe there's one that feels easier and more accessible for you. I'll go ahead and read them out loud. And if you feel like you have any sort of helpful reframes that might align with the verbal blending sort of idea, feel free to let us know. So this one on the bottom left says, "You can't force me to go to the hospital. I'm not waiting in a waiting room for hours." Another common thing we might hear in some of our participants, they have the complex health cases. This one on the top right says, "I'm not coming to the office to sign any more effing paperwork. I'm tired of this program." Maybe something our case manager, Kat, has dealt with or will in the future, right? And then this last example here says, "I'm just giving you the heads up that I don't plan on paying my rent next month, and I don't care what happens to me." Right? Feel free to take a stab at reframing any of these in a way that feels more collaborative and blended with the participant rather than coercive and punitive.
Yep. If a client said one of these things to you, how would you respond is essentially the next question.
I'll jump in here with the paperwork one. I've had this said to me numerous times.
Awesome.
I would commiserate with the person. I understand. I'm not a fan of all this paperwork either. I completely sympathize with how you feel. Is there anything I can do to make this feel less burdensome for you? Because I would hate to see you lose your standing in the program or lose your housing over something that might be fixable.
Yes, that's great, Laura. There's so many things there. One, I hear the trustworthiness and transparency. Key principle, just like, yeah, paperwork sucks, right? And normalizing that for this person. And then also, like, you could easily say, well, if you don't do it, you're going to lose your housing. But instead, this person wants to remain housed, so you're letting them know, like, I'd hate to see you lose that. And that's so much different than sign this or else, right? And that's what we want to avoid in trauma-informed care. We don't want to be threatening folks. Thank you so much for that example. And Kate, if you're unmuted to speak, we'd love to hear it. And if not, go ahead and mute your mic. Anybody else have any responses to any of these statements on the screen?
I was gonna say like the top left, is that one of them where I know we talked about like, okay, what time would work for you? Is there a set time that we could set up so that you're prepared for it and that it doesn't feel like a surprise?
Absolutely. Avoiding, so these weren't created with any sort of like form, like, oh, they need these trauma-informed care principles. They're just like, here's what we hear in our housing and like substance use spaces, right? So, but those are some of the things, right? I want to be able to avoid surprises for this folks. So asking somebody, like, hey, I hear you. What time is a good time? Or can we set up a regularly scheduled home visit where you will be home, right? Because it sounds like they're making a request here. Why can't you let me prepare for this, right? I want to prepare myself. I want to be dressed. It's an actual concern in a housing first place. People are in their homes and they're in their homes naked sometimes, right? So they don't always want you busting in their door. A heads up, absolutely. Thanks for sharing that, Kat. I think you're definitely on the right track there.
I wonder if, Kat, would you be willing to like frame that in like an actual statement that you might say, which is like the hardest part. I know, sorry to put you on the spot, but like, what would you actually say if? Because I think you're on the right track with the ideas, but how do you like get it across in a way that allows you to be in partnership with that person?
Yeah, I guess um I sympathize that it's difficult when people come in unannounced. Is there a way we could find a time that works for both of us that I could come for a home visit? Maybe.
I love it.
Okay.
Perfect. Yeah.
Yeah, that's awesome. And I think it's okay to like meet somebody at their door, go away, come back when they say you can, right? Because again, you don't need to win anything, right? If it doesn't fit in your schedule to come back that day, you don't have to go back that day.
Yep.
Yeah, the goal is not to win.
I also think this might be a good example of where we can use the one of the 5 R's of repair. You know what? You're right. I've been coming at really bad times and I haven't been giving you a heads up. Really, really sorry for that. I wouldn't appreciate it if somebody just dropped in on me. What if we find a time or whatever, whatever the second half of your statement is. It's a good opportunity to like come clean. Like, you're right. I wasn't being thoughtful about when I showed up for you, and I'm gonna be more thoughtful in the future. Let's collaborate on the right time.
Yeah. Susanna also put a potential response in the chat that says a possible response for the first one. I'm sorry that my visits have disrupted your schedule and made things feel rushed. Sleep and having time to feel prepared is very important. Is there a better time that would work for both of us? What's a way to communicate to give a heads up that I'm coming over? Can we set a time to meet consistently so we can both plan on it? There's just a ton of collaboration here, right? And I think that's well, folks want to know that they are in some control of their care and the services that they're receiving. There's another example that someone named Ryan put in the chat that says, for this health example down in the bottom left-hand quadrant, I'm hearing that you really want to deal with your health challenge, but it's too uncomfortable to deal with it in the hospital. Can we go together and watch
Miss
TV or
Burrell.
wait?
I said, don't you be sending no bullets email.
Thanks for that example, Ryan. I for folks who exist in like harm reduction spaces, or if that's also something you've interested or a lens you can work through, one of the things that we like to say is harm reduction requires a ton of creativity, right? So this example that Ryan's sharing is just such a real example, right? We want folk, okay, we're taking this hour drive across town. Do you want to DJ, right? What music do you want to listen to? Being creative in these ways is really how we get folks to engage in some of the care. That is really nobody wants to wait in a waiting room for hours, right? Sometimes that is the only way our participants get care is through the emergency room, and we might need to support them in doing that. Sometimes that looks like having a staff rotation to meet, right? If it's the end of somebody's shift, maybe someone's coming to relieve that person in the hospital so that our participant is staying there, right? And getting the care that they need.
Maybe it also looks like getting not as good of care, right? Not hospital-based care, some other medical care, but at least it's something versus nothing, right? They're going to refuse to go wait in that hospital, but they might go hang out at the clinic, like the van, the mobile clinic or something like that, because they know the wait is going to be shorter. They can stand outside and smoke while they wait. There's so many ways that is more comfortable. Is it the best medical care? No, but is it something that might be worth exploring? Because something is better than nothing in this case.
That's a good harm reduction tool also, that it may not be the ideal, but it poses the least amount of harm for the person or the situation. And sometimes it may be that you just need to remove that person from the setting. Ideally, they'd go to the hospital, but maybe you just need to get them away from other people. And just, think of it in terms of how can I reduce the levels of harm in this situation?
Absolutely. Alrighty. Anybody else have anything that they'd like to share and how we might be able to say any of these statements differently? Oh, Kirby unmuted. Awesome. Jump in.
I was just gonna do the last one. I was thinking I might say something like, you definitely, I can't make you do anything with your money. It's your money. But you've worked so hard to get into housing and to keep your housing so far. I would hate to see that all go away. And then I would probably ask, when you say you don't care what happens to you, what do you mean? And, is something going on that makes you feel like that?
Yeah, it sounds like there's some fear there, right? I'm not paying my rent. I don't expect to, and that might get me evicted, and I'm okay with that, is maybe what this person might be communicating. But I think you did a good job in acknowledging their autonomy and choice and not paying their rent, right? Uh, one of the other things that was included in the first or the second part that we did, I don't quite remember, but the idea of natural consequences, right? When people don't pay their rent, unfortunately, they're evicted, right? So our role when someone's saying this to us is not to say, well, you better, right? Or like, don't you know what happens if you don't pay your rent? People know, right? Um, so I love that. I love you like normalizing that this is your money and you can do what you want with it. And also acknowledging that the work that they've put in, right? That's where I hear the motivational interviewing piece being important in like the verbal blending space. Because you're like, you've worked really hard to get here, and like I want to support you and keep being that going, right? And in moving that forward. So way to
I would
go.
want to know why they weren't going to pay their rent. I would do some problem solving there because usually when people don't pay their rent, that money's got to go somewhere. Did they help a family member or a friend pay off a bill and they don't have their rent money and they're embarrassed to talk about it or they're scared they're going to get in trouble for helping somebody else? Did they relapse and
Mhm.
buy drugs instead of putting their rent money back? Those are problems that we can help them with, but they may be too embarrassed or ashamed to talk to us about it. So they put up this bravado of, well, I'm just not going to pay my rent and I don't care what happens to me. So I would do some problem solving there. And, maybe we can help your family member or friend get resources to help them with whatever they're dealing with rather than you using your limited funds. Or if you relapse, then let's talk about would you like some treatment? Would you like to go somewhere for an assessment? How can I support you? Because then it's kind of like the dishwasher scenario. It becomes more supportive rather than punitive.
Definitely. And I I appreciate that a lot and like what's going on. And I think one of the other one of the other forms this could take is if this isn't someone who usually pays their rent late or doesn't pay their rent at all, they might acknowledge that. And that might open the door to some questions, right? Like, wow, you're not paying your rent this month? This is the first time you've done that. What's going on? Right? Or like, you want to talk about that? It I think might be the gateway to what's going on, right? Whether that is like a substance use thing, a lending money thing, whatever that looks like. Letting folks know like, oh wow, that's not like you, right? You're typically on top of your stuff. What's happening here? All really good examples, folks. Thanks for engaging in that activity.
Yeah, I'm really appreciating the goody two shoes. They can't handle the awkward silence, so they must answer our questions. We rely on you people. Um, all right. Let me hit you with some quick takeaways and get you out of here. Thanks, folks. So, want to just do some really quick do's and don'ts about trauma informed care. Um, we do want to recognize that trauma informed care applies, and I think we've hammered this pretty hard throughout the series, to both participants and staff. We are people too. We have experienced our own traumas, and a true trauma informed approach is going to incorporate that knowledge and respond to staff and participant trauma. It's going to emphasize routine and predictability, right? We talked about expectations so much and boundaries so far today, and I think it's more of that. Um, I don't know if we've said this statement yet, but we want to really emphasize um, if we're dealing with our own trauma, we're going to have to put our own oxygen mask on first, right? Just like on an airplane, we have to take care of ourselves before we're able to turn our attention toward um, helping people cope with their traumas, which can be significant and will splash on us, right, in a secondary traumatic way. So Doing our own work is going to enable us to be better prepared. We can view behavior as a form of communication, just like in that last example. You're not paying your rent, you're communicating something, and I need to know what you're communicating, rather than just try and curtail behavior for the sake of it or for the power exchange of it. Let's listen a little bit more closely in between the lines. And then we can also view trauma through an equity lens, right? Trauma-informed care is a practice that is committed to equity, culturally responsive services. Culture has come up quite a bit so far in our conversation today. And culture as a location for trauma makes this all the more relevant, I think. Here are some don'ts. Don't personalize negative feelings, emotions, and reactions. People are going to respond to you through the lens of their own trauma. And I think if we take that personally, we will be hurt and we will not show up as our best selves when we're trying to support folks, right? It's not about you. It's about what that person has experienced and how they're responding to coercion and limits to their autonomy and things like that. We must not ignore the symptoms of compassion fatigue in ourselves. Similar to the putting our oxygen mask on first, if you try and power through it, it's going to be worse and it's going to show up in the care that we provide. This is a little bit like of a weird or more very concrete one compared to some of these more abstract ones, but maybe not using physical touch as an intervention. There may be times where you know that a particular person may be very responsive to a hand on the shoulder, but that's probably not the case for most people, and that may even be tied into some trauma. So kind of avoiding touch wherever possible. And then making sure that we're not using trauma-informed care tools when what we should be using is crisis intervention and de-escalation tools. We can be trauma-informed when we de-escalate, but want to make sure that we're clear that de-escalation may require, or crisis intervention may require, a more intensive set of tools or a slightly different set of tools as appropriate. All right, folks, we have reached the end. Thanks for bearing with us. Thanks for hanging around this whole session. I do want to invite you in the month of March. We're going to do 3 more sessions, and that's going to be focused on motivational interviewing. So kind of breaking down the ins and outs of that, some concrete practices we want you to be able to walk away with. So look out for that next Wednesday, same time, same place. Or maybe there's a new Zoom registration I think people need to go through. No session evaluation from us today, but I believe the Coalition for the Homeless probably still has theirs. Yep, you'll get that. Thanks so much for being here. Thanks for engaging with us. We appreciated all this time you spent with us over this month. So looking forward to more. Hope you have a great rest of your day.
Take care, everybody. Have a good day.
Thank you.
You bet. Thank you.